Okay. Guys, what y'all think about waiting one more minute? We have 21 participants on. Ali, is that good on your side?
That's fine. That's fine whenever you're ready.
Okay, so we almost have quarter century. I think we should start now. So, ladies and gentlemen, colleagues, welcome to the Defoot Awareness Week, the NACA chapter, which promises to be quite an exciting learning experience. We have four very esteemed speakers. And what we're going to do, just a little protocol, please stay on mute during the presentations. Video on and off is your choice. You can pose questions in the chat box. We will have a question and answer session, which will be held at the end of all presentations. And just for time's sake, let's get straight into the meeting. And I would love to introduce a good friend of mine, Dr. Kumar Sukraj from Guyana. He's the head of department of the Diabetic Foot Center at the Guyanese Public Hospital, Guyana Public Hospital. He's a part-time lecturer in the University of Guyana. He's a wound care specialist and diabetic foot care specialist. He's received two honors, the Hari Prasad Memorial Award and the Best Presenter Award back as an intern. From what I understand, Dr. Kumar is making waves in Guyana with the establishment of several centers that are doing excellent work at saving limbs. So let's go straight on to Dr. Kumar.
Thank you very much. Thank you very much, Dale, for the introduction. Good evening, everyone. And I hope that my presentation this evening will be one that is beneficial for all of us here in the Caribbean region. 1 minute, let me get my slide. So what I will be talking about this evening, I'll be talking about a Guyana experience in terms of developing a diabetic foot care service and how this model can be applicable to the Caribbean countries, seeing that our healthcare systems are somewhat similar in terms of its design. We all know that diabetes, if we get diabetes an inch, then it can take a foot. So that's something that is happening every second. Someone or every minute, someone is losing their limb to diabetes across the world. This is some stats here. They're just general global stats. And for 2013, there are about 382 million persons who are living with diabetes worldwide, and it's estimated for a 55% increase by 2035. And that's according to the IDF Atlas. Guyana, in terms of our population, 15% of our population, according to the Atlas, is considered to have diabetes. We know that 75% of people who are living with diabetes, they're either in low or middle income countries. Why it's important to know this is that when we are going to devise or design care methods, we have to take into consideration the resources that are available to people from low and middle income countries. In Guyana, diabetes is considered to be the fourth leading cause of death among the population here in Guyana. So in terms of developing a system to salvage limb or to manage persons with diabetes foot complication, in Guyana, it was an international collaboration between the partners from Canada as well as our local Ministry of Health and local partners here in Guyana to establish the Diabetes Comprehensive Foot Care Center across the country. For my presentation this evening, I want to reflect on some guidelines, some principles that usually would guide international collaboration to identify some of the scope of, in terms of foot problem, diabetic foot problem in Guyana. Brief evaluation of phase 1 and phase 2 of our foot care project. Of course, there are other phases in terms of our diabetes care project that move on to diabetes in pregnancy and retinopathy care, but I'm not going to touch on that this evening. And we want to consider how we can get everyone involved to spread or to establish more centers across the Caribbean. In terms of diabetic foot in Guyana, it's one of the consider the single greatest reason for surgical admission at the major hospital, which is Georgetown Public Hospital. And this is from when the project started, when the feasibility study and everything was done. There was approximately 250 patients per year that were admitted in the surgical for diabetic foot complications. 30% of these patients are usually on the surgical block, and they would have had either in there for limb-threatening infection, of which 42% ended up with an amputation, and half of that 42% usually would have a major amputation, either below or above the amputation. And from our average then, that the calculated value would have been like about 90 amputations per year. This is our current setting, well, not current setting, sorry. This was a setting pre-project in terms of before the project started. We had overcrowding at the diabetes care clinic, which is our medical clinic, which we consider. This is one of our dressing rooms here that was used to do dressings for persons with diabetes, and also due to limited space on the ward, everybody was in the open ward, more prone to infectious spreading of infection and so on. So this was pre-project setting that in our hospital system. Of course, these are all changed now. We have more modern facilities and so on. Typical example of a patient, and this gentleman here would have had one amputation and was in hospital now with the next limb being infected, and he's up for, or what is recommended for him is another amputation. There's a typical patient what we usually see on a daily basis. In terms of the project, the Guyana Diabetes Care Project, there were a couple of principles on which the project was developed, and some of the developmental principles in terms of their collaboration, quality improvement, context-specific, sustainability. These are all principles on which the project was developed, developmental principles, of which collaboration was a major or important part for the development of this project, and that is collaboration with our international partners as well as our local partners here in Guyana. And then, of course, there are clinical and research principles that were important in developing this project, this CARE project. And it was more evidence-based, informed medicine, knowledge translation into professional approach, into a multidisciplinary care approach, comprehensive care, patient-centered concern, patient-centered care. And there were educational strategies that were used to translate evidence-based and best practice to the caregiver, the care provider, sorry. It's just a slide to show that it was a collaboration between Guyana and the Canadian partners, and I will mention those partners shortly. In terms of the Guyana Diabetes Care Project Phase 1, we use a multifaceted educational strategy that we use to get best practice into practice. We adopt evidence-based informed diabetic foot care practice. We create a sustainable, comprehensive diabetic foot care system that is to date, after it was established in 2008, to date functional and improved. Also, the aim of the project was to optimize care in a resource-poor setting and to improve the outcome, the overall outcome by reducing major amputation. And this is despite there was an increase in admission. So the amputation rate went down with the project. You'll see that at the end, but there was an increase in admission, which is more patients would have required in-house hospital care rather than outpatient care. The 4 levels of education strategies that were developed for the project, that was utilized, for the project would have been best practice, recommendation, and there were CME presentations to get healthcare providers across Guyana to understand the importance of diabetes foot care. There was skill training. There were enablers that were developed to have more specific, what we call specific instructions to the healthcare providers, so they could follow and not deviate from the recommended practice. On-job training, and then many of our healthcare providers had an opportunity to do the course, international, the professional wound care course from the University of Toronto, and this would have created a significant impact in the approach to management of wounds, more so diabetic foot wounds. This is some pictures of some of the sessions and some of our international as well as our local partners that were integral in developing the project. Just some pictures. So for the project, for the Guyana Diabetes Foot Care Project, these slides are, what we consider to be like the summary of the project. So the project Phase 1 was established at the Georgetown Public Hospital, which is our main referral hospital. And this site is chosen because here is where we can have the multidisciplinary care team present. It's just that it was functional. However, everybody had their specialty, but it was not integrated. All right. The funding for the Phase 1 project was from the Canadian International Development Agency, and this was between 2007 to 2009. The phase of this project lasted. However, 2007 was used to do the needs assessment and to apply for the funding. 2008 and 2009 is when healthcare providers were trained, and the center was established at the Georgetown Public Hospital Corporation. So the facility, the room was existing. I think that was a minor operating theater that was designated for the project. So there were like 2 dressing operating rooms, and that's what at the major referral hospital. Key opinion leaders were trained So the key opinion leaders were the nurses, rehab specialists, and the medical doctors. And there were like two cohorts that were trained, and there were 8 persons who would have given the opportunity to do the International Interprofessional Wound Care course, and they became key opinion leaders in foot care in Guyana. In terms of other levels of training that was done, there were CMEs and there were also workshops and preceptorship that were done to train different players in the management of diabetic foot care. In terms of so in total for the phase 1, we had 65 trained healthcare professionals. They were trained in the management of diabetic foot as well as they were trained in wound care at the major hospital, Georgetown Public Hospital. And one thing that the project would have focused a lot on is screening because the focus was on preventing the problem. What is amazing here is that when the 60-second screening was introduced at the medical clinic, what was amazing is that their patients, when they go to the medical clinic, they never took their feet, or the doctor never requested for them to take their feet as a routine examination out of the shoe, as a routine examination at the medical clinic. So there were people who were going to the medical clinic and had high-risk features on their feet, and nobody knew prior to the project that these are all things that can lead. Not that they don't know it can lead to amputation, but it's just that they were not checking for it. So initially, when the project started, 1,226 patients were screened, and 48% of that patient load was identified as having a high-risk feature, either one of the high-risk feature. And there is a published paper on this. You could get it online. I think it's on PubMed on this particular aspect of screening using the INLO 60-second screening in Guyana. What were the outcomes and what were the findings? In terms of care, the care plan for patients at the project, at the Foot Care Center, it was designed based on best practice, and also it was designed based on evidence-based medicine. And more so what was applicable here is the womb bed preparation paradigm that was designed and is also tested and proven by the Sybil et al. This is Dr. Sybil from University of Toronto and some other, I think it's one of the leading wound care experts across the globe, Dr. Sybil. So this is what was developed by that team. And the womb bed preparation paradigm, as we know, has the major component that is treating the cause, local wound care, and patient-centered concern. And we would have trained these professionals in this paradigm. So when patients come, they apply this paradigm to the patient. And also, there were also additional training in comprehensive foot assessment, like how to do a vascular assessment, how to use a Doppler, how to assess a patient for superficial versus deep infection, which is our Nards and Stoney's aspect of it, in terms of how to use an infrared thermometer to check for temperature difference. So these were all on the job or on the ground training for the healthcare professionals, as well as these were all part of the foot care workshop. A big part of the project, which focused on plantar pressure redistribution, because this was really important to have an outset to heal. I will show you a few pictures shortly as to what device that was used to offload patients, and of course, surgical or conservative form of debridement based on the vascularity of the patient that has a wound on their extremity. And of course, it was back and forth in terms of the locals would have visited Canada, have some level of mentorship at Dr. Sybil's clinic, as well as University of Toronto with the IAWCC program, that's the Missionary Institute. So that, and then also we have our Canadian partners who visit. There were 4 visits over 18 months, and there were additional training, specialist training that when they visit, they would have organized here locally in Guyana. The Ministry of Health would have acknowledged and also integrate the 60-second screening tool into our guideline, diabetes management guideline, and that was made accessible to all healthcare providers across the country so that they could screen for diabetic foot complications. So in terms of plant pressure redistribution was a big part of our project, and the offloading or the cast, which would have been ideal in certain situations, but in terms of cost, it was too expensive to purchase for patients, and this is about 300 to 400 Canadian dollars. But what was the Darko or the Med Surge or the heel wedge was more ideal for our setting because also of the cost. Not as effective as the ear cast, but they're still effective and they did a wonderful job in offloading the ulcers. And this cost like around 40 Canadian dollars. So the choice was to use the cheaper one because we could not afford to buy the more expensive. So this was a major part, and it's still the government is still buying it for all our patients. And the rehab specialists usually when they assess and they do their pressure mapping of the foot, they usually recommend one of these for the patient. What is important to note when the project started, we had a significant reduction in the amputation rate, major amputation rate, and you can see the project started in between 2008 July to December, and you can see that there is a significant decrease in amputation rate across as we progress from 2008, 2009, and 2010. However, there was an increase in the admission on the surgical block because most patients now, when they come, they are subjected to a multidisciplinary care approach where internal medicine, surgery, and in some cases orthopedics and the wound care department, they usually admit the patient on the ward and manage the patient holistically. So the admission rate was increased, but the amputation rate was decreased. So for the phase one, because of the comprehensive care that was and the establishment of a center of excellence, a single center at the main referral hospital, we would have managed to establish a 43% reduction in the major amputation rate once the project started. And this project was sustained till to date, and of course there are expansions in terms of the capacity, in terms of training, their expansion. And I could say that this takes us from the phase one, when it was established in 2008, then we move to phase two, and that is to establish the same model that was developed at Georgetown Public Hospital to the different regions across the country. And that brings us to phase two. And phase two was funded by the Canadian International Development Agency. And this was between March 2010 so March 2010 to February 2013. And the goal here for this is to establish or to replicate this similar model in 6 out of 10 administrative regions across the country, where we could cover approximately 90% of the Guyanese population. And what happened during the phase two, however, 3 of the centers were only established in the last 6 months. However, it was still established before the project ended. And then when the project ended, it was handed over to the Ministry of Health. So the project really didn't end it. It's just that the partnership ended in terms of funding, and it was handed over to the Ministry of Health. And now the Ministry of Health is funding the project. And in phase two, there were 3 cohorts of the individuals that were trained, and eight persons per cohort with the IAWCC. So in total, we would have had like about 16 people who were trained with IAWCC, but there were 14 who, at the time of the phase 2, completed the course, and 8 were currently doing the course when phase 2 started. So when phase 2 ended, there were 8 people that were active during the course. So this is to emphasize the importance of training and to have this multidisciplinary care approach to diabetic foot. And for phase 2, what was important was the introduction of HbA1c testing. And this was important, especially because what was focused more on phase 2 was to have HbA1c testing and to also have effective management of hypertension across the country. Not that it was hypertension management wasn't part of our regular chronic disease, but more emphasis was placed on having targets, right? Was having targets. So those were added to the phase 2, and of course the training continued with the wound care aspect, and they were back and forth. They would visit and monitoring and evaluation of the project and auditing, of course, to see how much what impact is the project having on diabetic foot complications. So in terms of the two phases of the project, we have phase 1 and phase 2. The phase 1 is where we develop a center of excellence. Persons were trained at all levels in the healthcare system using the 4 levels of education. And then they were in clinic preceptorship where people were on the job training, and they were established or adopting the wound bed preparation paradigm for the management. And then we know for phase 1, there was like a 46% decrease in the amputation rate. For phase 2, on the other hand, is to take the phase 1 model and establish seven additional PFC across the country. Of course, the training continues like the same as phase 1, and there was introduction to HbA1c for the first time, HbA1c testing in Guyana. This is just to show the 10-year audit when it was done for the project, and you can see that there was a significant decrease. I'm not going to talk value now. You can always these are all published research, so you could get them on PubMed. So the significant decrease, of course, there sometimes it fluctuates, but it never went to where we started in terms of the number of amputations. So that's the outline of the Guyana Diabetes Care Project, the phase 1 and phase 2, in terms of the structured approach to establishing these centers across the country. And we just to acknowledge these main players at the initial start of the center. And our centers are doing well. Our centers are continuing to function, and we are now looking, with the Ministry of Health, is now looking to establish centers in the interior region, because what we see now is that there's been an increase in the diabetic foot complications in the Amerindian population. So we are now trying to establish, we recently finished a wound care foot care training for people in the region to start screening for diabetic foot complications. And soon, at least 3 or 4 additional centers will be established in the outlying areas. So that brings me to the end of my presentation this evening. I think question is at the end.
Yes.
Is there any question?
Kumar, thank you very much. So we're going to, we leave the questions to the end of the entire series. But before we go on, we want to play a video by the President, Dr. Abbas. I think Ali will take us through that.
Yes, thank you very much.
It is an honor and privilege to address you today as President of B-Food International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. B-Food International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low, middle-income countries. As diabetes rates surge, so does the incidence of diabetes-related complications, including food-related complications, which is our focus of action here at B-Food International. Our mission of B-Food International is resolved and clear, ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action, demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare professionals are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at B-Food International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of B-Food International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of B-Food International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, B-Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Okay. Thank you, Dr. Abbas. And moving right along, I would like to introduce Dr. Brian Lipau. He's a board-certified podiatric surgeon practicing in Houston, Texas, specializing in diabetic foot amputation prevention and limb salvage. He maintains staff privileges in all major medical institutions in the Houston area. Dr. Lipau holds dual academic appointments in the departments of internal medicine and cardiovascular surgery at the McGovern School of Medicine in Houston, Texas, as well as the Bayer College of Medicine in the Division of Vascular Surgery and Endovascular Therapy. He has a strong interest in giving back to the community most recently starting a team of riders for Houston's Tour de Cure in support of research to help find cure for diabetes. Okay, Dr. Lipao, you can take over.
Great. Thank you so much. And thank you to everyone at D-Foot International and for the gracious invite. Happy to be here today to share a little bit about my experience here in Houston and in the U.S. with diabetic limb preservation care. Today, we're going to chat a little bit about the toe and flow model. Most of us are familiar with that, and a multidisciplinary care model for the management of the diabetic foot. Again, my name is Brian Leap. I'm the current Chief of Podiatry, Director of Operations at Hope Vascular and Podiatry in Houston, Texas. No disclosures pertaining to my lecture today. So as we know that diabetic foot complications are extremely complex. You can see from this graph here that, diabetes, diabetic foot infections, and diabetes generate significantly high referrals and revenues in number of patients per visits and physicians' times per year. It's exceedingly high. More importantly, the hospital admissions, inpatient and both outpatient, are soaring numbers here when compared to other comorbidities such as heart failure, cancer, and obesity. Diabetes and diabetic foot infections far exceed those number of visits. And so it's a very complex complication, and a huge problem for the healthcare system, I believe worldwide, but specifically here in the US. And our job is to work to do a better job at streamlining the processes, working towards shifting more of that inpatient care to the outpatient setting. And that includes working with people to establish proper protocols, algorithms, early intervention, rapid intervention, and implementing the toe and flow team early to help reduce higher level amputation, unnecessary lengths of stays, and high readmission rates. Diabetic foot complications are common. This is the global burden of the disease. This is showing just demographically sort of the years lived with disability and then those that experience the disease process. And you can see diabetes and the related complications are one of the top 10 reasons for the global disease burden in the US. There's many publications out there currently talking about sort of the toe and flow model and the importance of the toe and flow model, the impacts of establishing an integrated interdisciplinary surgical team on the diabetic foot. And you can see here that the need for that is really, really critical. And in the US, really key components for successful limb preservation teams include the podiatrist and the vascular surgeon. Those are really the key hallmark components of that toe and flow unit. And then from there, we sort of branch out and include ancillary services, which are vital and very important, but that also includes diabetology, nutritionists, orthotics, prosthetics. I firmly believe that mental health counselors should be a very important part of the algorithm when managing sort of a comprehensive toe and flow programming, and also having people in-house that can manage the A1C levels on these patients. Again, we're looking to streamline sort of patient care. Like many of us, management of the diabetic foot is a very complex and costly problem for our healthcare systems, and we're constantly trying to find a way to reduce that. Again, the limb salvage team really kind of starts with kind of the outpatient services, the medicine service, and the emergency medicine services. They should be contacting the limb preservation team. And then from there, surgical intervention consultation services can then take place in the hospital setting. The overall toe and flow limb salvage service, both podiatry and vascular working together to serve in the same inpatient and outpatient services. So what's transitioning from the inpatient should also be common and should follow along with the outpatient services in order to establish the proper sort of flow pattern for these patients in order to ensure successful outcomes and thus getting those patients into early diabetic foot remission. Again, just demonstrating the reduction in diabetes related to amputation rates when implementation of a multidisciplinary model. This is out of Canada here from some of our colleagues, sort of establishing what it looked like pre and post establishment of a toe and flow model. You can see both on the right-hand side, the sort of the area where these models existed, and you see how dramatically reduced those amputation rates are when you start implementing those programs, notably toe and foot below knee and above knee amputations, significantly reduced once that model is implemented versus when we don't have that model there. And so the team does work, and we're here to talk about how that team works, what are the critical components, how each one of us can work to set up these teams in order to ensure success, not only for our patients, but help to do our jobs to ease the burden on our healthcare systems, ease the burden on the patient population, and ensure these patients are showing up at the hospitals and receiving the care that they deserve when they get there. The quintessential four-step approach to toe and flow model, as created by Dr. Armstrong, who is one of my mentors, and I trained under him, really starts with kind of the limb preservation program itself. We established that core limb preservation program. From there, it's a four-step approach system in order to make sure that we kind of stratify and really manage those patients in an effective way. One would be initiating what we call the hot foot line service, and that would be if somebody comes into the ER, we're contacted immediately. I'm constantly educating our hospital systems that when these patients hit the ER door, call us immediately. It'd be the first thing they should do before they're ordering a bunch of unnecessary imaging studies, calling a bunch of unnecessary services that are only going to perpetuate the problem. Get the toe and flow team involved early, and we can certainly help to reduce those unnecessary tests and examinations that will really not give us much more information. Once you have that hot foot clinic line, they can help to, record and evaluate both major and minor amputations, reduce that high rate amputation level to a more low rate amputation level. So as opposed to taking a below knee or above knee amputation, we're talking about maybe a toe or a midfoot amputation to help reduce the length of stays, but also keep the leg. We know that the mortality rates are quite high for individuals that undergo a major amputation, approaching I think the current data tells us that there's a 70% risk of death in 5 years post major amputation. So, our job is that we may do more minor procedures on these patients, but in effort to save the foot. Then we have the active tissue loss clinic, again, reducing the high-low amputation rate scenario, and then the time to healing. The remission clinics, once those patients have been into the system, we want to make sure that once they're in diabetic foot remission, we keep them in ulcer-free days, monitoring activity levels via various technological devices to help monitor steps and things along the lines of that. And then the screening clinics. And those screening clinics really are for risk stratification, rate of ulceration, and risk of hospitalization, how we can really reduce the initial burden of the reason and hope kind of reset the clock and prevent those patients from even getting into that active acute care phase. Again, kind of how our models work here and what we sort of base our systems off of. We have the toe and flow outpatient clinics. Ideally, these clinics can be run by advanced practitioners. The core, again, of those programs are going to be the podiatry and vascular components, but they can be APP run clinics. Fast, easy communications would include the hospitalists, infectious disease providers, the EDs, and outside referrals. Toe and flow inpatient service should be set up as a 24/7 service, staffed by both MDs and DPMs, collaboratively working together to help kind of funnel into the outpatient clinic setting. Again, wanting to reduce the burden on the inpatient side, moving those patients to the outpatient side and helping better manage them in the outpatient setting to reduce, again, the length of stays and all those terrible things that happen once patients wind up in the hospital. Those length of stays get quite onerous, and certainly we all can speak from our experiences that once the patients get in the hospital, they may be going in for a minor procedure such as toe amputation. Next thing you know, they're in the hospital 2 weeks because they suffer some sort of morbid event secondary to some of their comorbidities that they bring to the hospital. Kind of the standard outpatient toe and flow model. Again, we'll break this down by podiatry and vascular. On the podiatry side, we've done a little bit further, even streamlined that four-step process. Our clinics are now run as preventative care clinics, where we have patients that get referred in that have not had a history of an ulceration and who have not had a prior amputation. These are patients that have either poorly controlled diabetes, high A1C levels, and or neuropathy. And we target our endocrinologists, our internal medicine teams to help get those referrals into our clinics. This also includes the nephrology groups, those patients who are undergoing dialysis. All those patients should be screened in a preventative care clinic measure. We have a bunch of technologies and cool things that we can do to help pre-screen these patients in order to help predict the early formation of a diabetic foot ulcer. Then we have our acute care and tissue loss clinics. These clinics are for right now, are going to be a necessary part of the things that we do. We get a lot of referrals from colleagues all across really the state, sending patients to us that really have what we call no options. And I'll get into some clinical cases as we progress along in this lecture. But the idea really is to have the ability to manage these patients in a more effective manner. Most of these patients are coming to us having been told they're going to lose the limb, and our job is to try to do as much as we can to try and salvage that limb. And then again, the remission clinic. So once those patients have been through the process, have had a diabetic foot ulcer, and we're now in remission, we can stratify them into remission clinics, find the proper way for them to be screened and followed up on a routine basis to ensure that they stay ulcer-free and extend their ulcer-free days. On the vascular side of things, again, it's working hand in hand with the vascular surgeon and the podiatrist. We share clinic space. Having and seeing these patients in an outpatient setting is really helpful for these patients. In the past, somebody would come see a podiatrist and they get referred to a vascular surgeon, then they have to go somewhere else for vascular studies, and they may have to go somewhere else to have a vascular procedure, followed by going somewhere else for a surgical procedure on their foot, and that does include orthotics and prosthetics. And you can only imagine that a lot of these patients have restricted incomes. They don't have the ability to get from place to place on their own, and so it really creates really puts a lot of onerous work on the patient and their family to be able to get them to all these appointments. And that doesn't include all the other doctor visits that they have to go to. So by creating sort of a comprehensive unit, our job is to help streamline these so we could control a lot of those variables under one roof. Again, on the vascular side, we have the side-by-side clinics with the vascular surgeons, vascular non-invasive labs here in our clinics, and then an office-based cath lab. Again, reducing the burden on the hospital, keeping those patients hot out of the hospital, performing the procedures in the outpatient setting. They recover here and they go home the same day. The inpatient toe and flow system is a little bit different, kind of similar as we would in the outpatient. But again, we're working to streamline sort of what's happening on the inpatient side as well, because unfortunately, at least here in the US, a patient comes into the hospital and they can go to any number of hospitals in Houston alone and can have various pathways of what happens to them when they come in with the diagnosis of a diabetic foot ulcer and or diabetic foot infection. For us, we're trying to standardize that, streamline it so we can better manage this patient population. Again, shift that inpatient process to the outpatient setting. Podiatry, the ideal setup for podiatry inpatient services to have daily OR block time. These patients are critical. It's unrealistic to have us limiting our OR time, having cases done in the middle of the night. It just reduces the ability for us to take care of these patients. So OR block time is something that I always fight for, and I can usually fill that block time quite rapidly. And again, most of the procedures I do, from the most complex reconstructions to a simple toe amputation, really are under an hour. So we could really fill an OR, be expeditious about the work we're doing, and be cautious about the time we're spending in the OR. Wound care coordination is also that next step. We work closely with our WOCNs and also with the inpatient wound care teams to help kind of manage and streamline the patients that are in the hospital, how we can best care for them to shift them to the outpatient care. And then the APP training rounds, we will do these quite frequently where we all round together on our patients. I think that helps not only from a teaching perspective, but also, again, helps to create that continuity of care. Both the vascular surgeons, their team, the podiatrists and their team, and sometimes the APPs as well as the WOCNs will all round together so we can have a quick, comprehensive plan early on so everybody has the expectation of what things are going to happen with this patient. Again, helping to reduce those length of stays. A lot of the length of stays come from miscommunication. So if you can establish that communication early on, things will go much better. The patient's experience will be a lot smoother. And again, we can reduce those hospital length of stays. On the vascular side, doing non-invasive diagnostics are a critical part of the inpatient team. Again, having that daily cath lab block time is also really important. It's hard for us if we're trying to manage a high volume of these patients to not have block time in the OR, constantly getting bumped for what they would call more emergent type procedures. It's important and unfortunately a necessary part of these hospital systems, but for running and managing a successful toe and flow service in the hospital, it doesn't work. We need to have dedicated block time for those patients, and also dedicated OR and block time in the main OR for those open procedures that may need to get done and things that can't happen in the outpatient cath lab setting and or the inpatient cath lab setting. And this is just showing sort of the quintessential day that we have. This is just a few of our awesome team members here. But again, it goes without saying, it requires a village to manage these patients. From the vascular surgeons to our APPs, from our surgery schedules to the MAs, we are all just as important and critical part of the team to help manage these patients. And without each one of these individuals, our teams would not be successful. We've also implemented telehealth with the advent and sort of our days of COVID times. We've had to pivot quickly to be able to help manage these patients. And so while I don't believe telehealth is great for a lot of things, I think it can be good for initial screenings and sort of general follow-ups for these patients. Unfortunately, there's nothing better than seeing, touching, smelling, and doing a physical exam on a patient. And so I don't think that'll ever go away, but I think implementation of telehealth is one way that we can kind of do some outreach to patients who live 3-4 hours away that may not necessarily be able to come in to see us weekly, set them up with outpatient wound care at their home, have a remote telehealth visit, maybe 1 week, and then they come see us that every other week. And so that kind of helps to streamline that and ease some of the burden for these patients. Effective communication. Again, I can't say this enough, and I'll continue to express my need for effective communication, because without effective communication, our patients will ultimately fall through the cracks. And again, just kind of showing sort of the quintessential what we call our love chat with Dr. Montero and myself. This is kind of a typical week that we'd see of our patient population here. And just, this goes to show how much coordinated effort is involved in managing these patients. It's constant communication, constantly talking to each other and establishing a plan of care on the fly in order to make sure these patients get well taken care of. So why do these teams work? Well, I'll show you. We're going to go into a couple of case examples here on how the Tone Flow team works together in order to help manage some of these complex, this particular case, CLTI patients, and how we work together to help resolve some of these more complex patients. This is a 63-year-old female, sort of a classic patient, diabetic, hypertension, hyperlipidemia. She had a prior hallux amputation bilateral that failed, had a failed revascularization of the left lower extremity, followed by a failed hallux amputation, which led to a failed transmetatarsal amputation, was told she was going to lose the limb. This is how she presented to us. Again, you could see a dehisced transmetatarsal amputation, and we actually see quite a fair amount of these. I think at the height of my time, especially in the inpatient setting, I was doing 6 to 7 transmetatarsal revisions a week, which most podiatrists don't do in a year. So that the volume is certainly there. But a lot of these people get kind of mixed up in the system. They wind up in an outside hospital. Somebody sees this and they decide that this is non-salvageable when they cut the leg. I see this as an opportunity. You have a good plantar flap. If you have a good reconstructionist for the vascular component, you can get these patients really helped in an expeditious way. In a lot of these cases too, it's important to note that we want to make sure that we're creating functional outcomes for these patients. So we have the toe and flow model, but now we sort of call it the toe, flow, and go model. It's important that these patients have functional outcomes. Again, not every patient is going to come to us having exceptional functionability, but a lot of people do. A lot of people come to us having both legs, and we want to make sure that we keep them moving, keep them an active part of society, working and taking care and providing for their families. There are patients that come that have had prior below-knee and or above-knee amputations, and those patients may be looked at a bit differently and treated a bit differently, but keeping that leg is just as essential for transfer pivoting. And so, every patient is different, and I think it's important. You can't necessarily say that every person that has a wound is treated the same. Every person that has a wound is different. It's important to treat the whole person and not be whole in the person. So you can see kind of the both pre and post-operative angiograms of the patient. Really, this is one of those patients that's got no flow distal to the the hindfoot area, undergoing successful revascularization. Here you can see where the need for revascularization to carry blood flow distally out to that transmetatarsal amputation. That's why that foot didn't heal in the first place. Here, procedure is being performed. This is a sort of a new procedure that we've been doing a lot of work with called the deep vein arterialization. The procedure has been done for quite some time as an off-the-shelf procedure. A company called LimFlow has now popularized this procedure and just has received FDA clearance to be able to do this procedure. But really what this procedure does is create options for what we would consider at the time a no-option patient. Those no-option patients, those that have been told that there's nothing more that can be done for them in facing amputations, will hopefully soon be a thing of the past. And so how do we get a foot from the picture on the left to a healed foot? Well, it does require some effort. And once that patient's been successfully revascularized, we debride the foot, remove all the necrotic and non-viable tissue. We use various skin substitute products to help bridge the gap from tendon and bone coverage to get them onto a more granular, healthy wound base. And for these large wounds, split thickness skin grafting is the end game for these patients. And you can see here the skin graft kind of incorporating. It's an off-the-shelf type product. I typically use this in conjunction with negative pressure wound therapy to help sort of bolster the graft, but also kind of limit some of the exudate that's there. Here you see kind of the bilayer graft, sort of that top layer kind of peeling off here. This is that underlaying surface of the graft. And you can see around the periphery, this is not necrotic tissue. This is just part of that product that's integrating into the wound bed. We leave this and set this for a couple of weeks. Negative pressure wound therapy is now employed. And then the patient goes on for a split thickness skin graft. Here you can see a fresh split thickness skin graft applied. We usually, when we do our split thickness skin grafts, they're applied under negative pressure for 5 days. Negative pressure is released, and then we do basic wound care here. And this is sort of the ultimate result here. And again, the whole time frame from when the patient saw us to when healing takes place and the patient gets in diabetic foot remission is only about 8 weeks. At the most, they go out about 3 months, but we like to really kind of keep those patients in those 6 to 8 week mark. And by no means are these isolated cases. This is something that's been reproduced over and over and over. We have well over 100 cases that we've done quite successfully in that time frame. So how do we get from here to here? You've seen kind of the results, how we've taken this foot that really was told that there's not much we can do. We just saw this wonderful person in the office the other day. She's now 3 years out post deep vein arterialization and her guillotine transmetatarsal amputation. And she's really doing great. And here you can see sort of that kind of, this is what that flow pattern sounds like. And yeah, this wonderful lady here is able to walk and ambulate. And this is her kind of early on now. She doesn't have that antalgic gait anymore, but she's ambulatory and is living life. And so I think it's really great that we're able to provide some success to these patients. And the neat thing is that these arterialized patients, over time, as that arterialization site matures, they actually wind up converting over into having more arterial flow. You can hear her on the Doppler signals that has a biphasic signal there, which is really great. So again, working together to prove the model works. And I can't say this enough. You know, there's many publications that are out there. You know, this is just some of the few that we've been involved in. But again, as the one thing you'll notice is that all these publications are with multidisciplinary teams. Again, we're not unique here in the US. These are just a sampling of a few of the publications in the high yield journals that are out there. But again, it's pretty cool to be a podiatrist and you know, being published in the Journal of Vascular Surgery, Journal of Endovascular Therapy. Prior to probably 10 years ago, that was kind of unheard of. David Armstrong was really the sort of the one that kind of set the stage for this, and some that came before him, but he's really the one that sort of set the stage for the quintessential toe and flow model. And so I am just kind of living by him and hoping to continue that, as he would call it, to spread the spicy salsa amongst those, not only here in Texas, but all across the US and hopefully across the world. And so, you know, our hope is to continue to make a big impact on this patient population. There's a lot of work that needs to be done with our patients, but we're continuing to work to it. And you know, now that I'm working here in this private setting, our goal is that hopefully we can continue to further streamline care and set the standard in the model for successful outpatient therapies in the Houston area. So lastly, diabetes and CKD have overtaken PAD, at least in this Texas market. Now, we see a decent amount of patients that do have peripheral arterial disease alone from smoking, but diabetes and CKD really have kind of overtaken that. Most of the patients that we see have advanced CKD, and those are the patients that are really the hardest to kind of get revascularized. Foot-related complications are driving healthcare costs out the roof, not only here locally, nationally, but also internationally. And so we know that we have a duty to find a better way, how to cut costs without cutting significant, impactful markers in care for these patient population. Costs are related amongst other podiatry cares. We know that teams reduce amputations. There's a ton of publications out there that say that it does. I live it, I speak it every day, and I know that without the team approach, my patients and my success rates would not be where they are without working with a close team. Classifications can act as doorkeepers of care. I think classification system and models are great. There's several great classification systems currently out there. The Wi-Fi model is what we really model a lot of our patient care off of. And we're currently working on some newer generation type classification systems to help better streamline when to intervene from a podiatric perspective and when not to intervene, and when you'll have success and when you may not, based off of sort of a spinoff of the Wi-Fi model. Pure toe versus flow versus combined models. Again, I think you have to have a combined model at this stage of the game in order to help better kind of predict the outcomes and success for these patients. building that team takes a lot of energy and dedication. This is not something that's going to happen overnight. You have to find what we would like to call our soulmates, S-O-U-L, soulmates. And by that means that we sort of live and breathe this stuff day and night. My vascular colleague, Dr. Miguel Montero Baker, and I not only are colleagues, he's my flow amigo, but we're also friends. We respect each other. We respect our differences and opinions, but we're also there to kind of work together with the ultimate goal to help these patients heal. And then lastly, it really all leads to better overall health and care results for these patients. By no means am I saying we are the essential or the only components to the model. Again, that tone flow model is really important, that it expands upon far above what we do, but the core system of the model really happens to be the podiatry and vascular components to help manage this complex patient population. So with that, I thank you very much for your time. Again, appreciate the opportunity to speak to you today about my experience, and I look forward to listening to the rest of the lectures today. Thank you very much.
Brian, thank you very much. I look forward to visiting your institution to learn about venous arterialization.
Please.
Going right. Thank you. Thank you. So going right on to our next talk, we have Dr. John Huang. He's a general surgeon and physician-led at the Fraser Health Complex Wound Center in British Columbia. John has specific interest in the optimal delivery of interprofessional wound care as well as physician engagement in quality improvement. John, take it away.
Thanks very much. Let me just pull up my slides here. All right. Perfect. So thanks so much for this opportunity to speak. This talk is largely based on a publication earlier this year in the British Medical Journal Open Quality. If you want a free PDF, feel free to scan the QR code here. I have no disclosures. I'm a general surgeon in the Vancouver, Canada area. As Dr. Maharaj already said, I'm the physician lead at the Fraser Health Authority Complex Wound Clinic, which I'll be telling you a little bit more about in just a minute. And I've been a board member for Wounds Canada for a couple of years now. For those of you who are unfamiliar with Canadian geography, British Columbia is on the west coast of Canada, and my health authority is in British Columbia. It's this little orange plot called the Fraser Health Authority. It's on the west coast. And the Fraser Health Authority is made up of 13 distinct municipalities. Each one has their own hospital. And while the land mass of the Fraser Health Authority is small, it's only about 2% of British Columbia, we have about 40% of the population of our province. So that's about 2 million people. So about 1 in every 20 Canadians lives within our jurisdiction. Now, my clinic, the Complex Wound Clinic in Fraser Health, was founded in 2013, and we were originally envisioned as a home care support. Well, what does that mean? Well, in 2013, our executive noticed that about half of our wound care clients in home care were receiving treatment for more than 12 weeks, so our definition of a chronic wound. And so at the time, it was thought that there were about 1,700 chronic wound patients in home health actively getting care, and probably another 1,700 or so so-called self-care maintenance wounds that were taking care of their own wound care, but we were looking after them. So about 3,400 chronic wounds in the Fraser Health Authority that we knew about. So our mandate, our clinic mandate, was to try and engage these patients, to take over their care, and to get them out of our system by achieving healing. Now, of course, being in Canada, we did have a few service parameters. First of all, we were to be a multidisciplinary clinic, which at the time meant that we had a single doctor, a single wound care clinician, and a nurse, and the doctor was only available 1 day a week. We were also not resourced for any higher level of care. So it's not like we were gifted with a hyperbaric chamber or lasers, We didn't have any increased operative time. Certainly, we don't have a toe and flow model clinic here. We only really had what was available through the home care wound clinics. And then finally, we were largely just a consultative service. So we only see these patients one time or at best infrequently. And the majority of wound care still occurs in the home care offices. And so that's what we were dealt for the first couple of years. That's what we worked with. And I think our early data largely reflects our initial mandate and resources. Our average wound care patient had their wounds for about 205 days, so slightly less than 7 months before they even saw us. It took us, on average, about 6 months to achieve healing, 181 days. And unfortunately, we were only able to achieve healing in about 30% of our cases. So by any metric, for the first couple of years, rather dismal results. What's even worse is that after an initial decrease in the number of chronic wounds, we started to see those wound numbers climb up again. So we weren't even able to satisfy our initial mandate of decreasing the number of regional chronic wounds that we were facing. So obviously we were quite upset with these results, but we did learn from our experiences in those first years. So some learnings: first of all, chronic wounds are really, really difficult to heal. Next, the standard of care, particularly in certain community settings, isn't all that common. It is actually quite uncommon. And finally, chronic wounds are predictable. That is, patients that are susceptible to develop wound chronicity tend to have identifiable risk factors. So the adjuncts to these three learnings are, obviously, newer wounds are much easier to heal than chronic wounds. Next, systems can be built that increase the likelihood that standard of care will actually be delivered. And finally, we can actually identify and treat early patients who have risk factors for developing chronic wounds. And so this was really the context behind our quality improvement study that was published last year, but most of the work for this was done in 2018, 2019, so a couple of years ago. We took our three learnings and we came up with a hypothesis that by targeting high-risk patients for chronic wounds, for earlier referral to the complex wound clinic would lead to faster healing. And so we identified our high-risk population as those with a history of vascular disease, a history of chronic non-healing wounds, and then patients with a diabetic neuropathy. And then to identify them early and actually see them earlier, we did a couple of things. We modified our referral form, actually telling people, these are the risk factors. We want to see these patients early. And then we took that referral form and we took it to the home care offices. We took it to a number of family practice groups, and we told them this is what we want. And really, that's all we did. Very, very simple project. And so we were actually able to reduce our referral times very, very quickly. Within about 2 months, we went from an average of 205 days down to 95 days. So a reduction of about 55% within 2 months. And then because we really believed in our hypothesis that early referral and diagnosis and treatment would lead to faster healing, it was not a huge surprise to us that we actually reduced our healing rates by about 60% as well, from an average of 181 days down to 73 days. And even more importantly, we noticed that our ability to actually heal these wounds went up from 30% to 92%. Now, something else that we did with our study was we did some work around return on investment. So we looked at every wound-related medical encounter for a number of patients before and after being seen in the clinic. And we did this in collaboration with our regional finance department. So we used their numbers. And then we also worked with the University of British Columbia Sauder School of Business, so our provincial university MBA program. And we postulated that because chronic wound care is so expensive, that by healing these patients earlier, we'd be saving a ton of money as well. And I just want to focus on our diabetic foot results. What we showed is that for every diabetic foot ulcer patient we saw, we were potentially saving upwards of $58,000 a patient. So a cost avoidance of about 93.5%. Now, some of you might be thinking, how did we come up with that $58,000 number? And so, a couple of learnings from our business case assessment were that chronic wound care can actually be done really, really cheaply. In fact, you can often teach patients or their families to actually do the care. So you're not even paying for nursing care, you're just paying for supplies. And again, that can be done really cheaply. But the major factor in the expense of chronic wound care, and something I'm sure everyone on the call is aware of, is that every chronic wound patient is a ticking time bomb. And the longer they have these chronic wounds, the more inevitable it becomes that they will develop some sort of really expensive complication, something that's going to require a hospital admission, such as a sepsis or osteomyelitis or an amputation, sometimes even death. And so going back to our original title of the study, do you want to save millions in wound care? Well, in our system, how do you actually save $1 million? Well, you take that $1 million and you divide it by our cost savings or cost avoidance of $58,609.15 per diabetic foot ulcer patient, and you get 17 patients. So all you need to do in our system is see 17 diabetic foot ulcer patients and get them the treatment that they actually need early. So again, our hypothesis that targeting patients early at high risk for chronic wounds would lead to faster healing, 100%. Absolutely, you're probably saving a ton of money as well. So where do we go from here? Well, you'll remember that initially I said we barely made a dent in our home care chronic wound numbers. And indeed, we're a very, very small, probably under-resourced service. We have a very small regional impact. So one of the questions we're looking at now is, can we actually spread our results across the entire region? And then looking at our original 3 learnings, can we actually build a system where the care that we provide to diabetic foot ulcer patients at the complex wound clinic becomes the standard of care throughout the entire region? And so one of the questions we've really been asking ourselves is, well, why the heck is standard of care so hard to deliver? Well, a gentleman by the name of William Edwards Deming, who most would consider to be the father of modern healthcare quality improvement, has said that every system is perfectly designed to get the results it gets. And so it follows that if you have bad results, and we do, really bad results, it's because our system is designed to get exactly those results. Well, what does this mean? Well, consider this. Let's say you have a diabetic foot ulcer patient. What are some of the considerations in their care? Well, of course, you have to look after the wound care. And so maybe you don't do that yourself. You need to engage a couple of services that do that. And then, well, they're also diabetic. So you got to take care of their blood glucose, and you want to make sure that their diabetic care is perfect. So then you engage a couple other services for that. And then you have to consider offloading because they're all neuropathic. So again, another couple of services for that. And then, of course, there's all these socioeconomic determinants of health. And we know that diabetic foot ulcer patients, especially the bad ones, they're often poor, they're socially disadvantaged. So again, a number of services that you need to engage for that. So in this sort of context, it's not hard to understand when you understand what actually goes into treating diabetic foot ulcers, why it's done so poorly in the community, and why doctors and nurses in the community have so much difficulty coordinating care. But beyond that, they're also faced with a number of roadblocks and impediments that don't actually allow them to do their job or to do what they're trained to do. Well, what do I mean by that? Well, consider even in my home province in Canada, a wealthy, affluent nation, 60% of British Columbian adults have limited or no access to a family physician. We're also facing an unprecedented nursing shortage with no relief in sight. And think about this one. Last year, 1 in 15 Canadians accessed a food bank. So we can't even afford food, let alone an offloading orthotic. And so again, what is a doctor or nurse supposed to do about this? And we've all heard the same sort of ideas. Well, we need more education around diabetic foot ulcers and how to treat these patients, or we need more nurses or more specialized care, or maybe governments should fund orthotics. And, while these are all great ideas and probably part of the final solution, I would say, well, haven't we tried that before? And, what makes us think that this time, by pouring more resources into doing exactly the same things, that we're actually going to come out with a better result? And so I think I'd like to propose something different. I think we need to redesign the entire health system to empower positive outlier services like the toe and flow, like our complex wound clinic, like what they've developed in Guyana. And we want to empower these services that provide excellent results to see more patients. So let's say, for the sake of argument, we have a new diabetic foot ulcer patient in the middle of Fraser Health. Now, in the typical model, they go to see their family practitioner or a nurse practitioner, or they go to a walk-in clinic if they don't have one of those, or they go to the emergency department and they coordinate care. Well, I propose, what if every single diabetic foot ulcer patient was referred or sent to the complex wound clinic? Because frankly, our results are better than anyone else's in the region. And then it would be the responsibility of that complex wound clinic to coordinate care, something that we do lots of, we're good at, we've streamlined a lot of the processes. We would do this in collaboration with the family doctor and home health for continuity of care. Now, obviously, there are problems with this model. I've already said we're a very small clinic with a small impact. We have a catchment area of 2 million people. How can we possibly see every diabetic foot ulcer? Well, let's just suspend reality for a moment and think, what sort of system would we actually need to design for this to happen? And let's say, for example, there is a wound care clinician at a home health office in Fraser Health, and they are seeing a diabetic foot ulcer patient without a family doctor. So they don't have a family doctor. They're one of the 60%. We know that after that assessment, they're likely going to need a bunch of things that require a physician order. Well, what if there was a regional clinical pathway where a lot of these things were outlined and the wound care clinician could actually just make a list of what he or she needed? They would call the complex wound clinic and order something called a 3-minute rapid virtual consult. They would very quickly receive that appointment. So within an hour, they're talking to the doctor. They review the patient. They tell the doctor what they need, and the doctor sends them what they need instantly. And then together they document that interaction on a template just for medical legal purposes. That whole process of consultation and documentation and orders takes less than 3 minutes. Obviously, there are a couple of things that you require for this sort of system. Now, obviously, there's going to be some sort of acceptance of standardization of care, which is really, really difficult, particularly for physicians who see it as an affront to physician autonomy. You need a quality control system to make sure that these results are delivering a better outcome than the previous case. You also need a lot of patient buy-in, because in this system, they're never actually seeing a physician, which can be quite unsettling for a lot of clients who are used to seeing doctors for everything. Then obviously, you need a ton of trust between that wound care clinician and the complex wound clinic physician. And that's probably the most important factor. And I can tell you, we've already started doing this. And in fact, it does take less than 3 minutes. But I don't talk to anyone aside from the wound care clinicians. I don't talk to family doctors. I don't talk to emergency physicians. I don't talk to clinic nurses at the wound care clinics, because I only trust the assessment of the wound care clinician. So that in itself is a limiting factor. What happens if you have a patient in the middle of nowhere who is not hooked up with a home care wound care clinician? How do they access services across the region that they need? Well, I think that addresses why you need a systems view, and you actually need to build the infrastructure to make things work. And so what we're trying to do in Fraser Health is develop local networks of frontline staff who are supported by wound champions, so people who have an interest, although not necessarily a specialty in wound care, who are in turn supported by one or several wound care clinicians, depending on the need and service. And again, we want to establish these wound networks across the entire region. And then these wound care clinicians become the access point to the complex wound clinic, which then coordinates care in collaboration with the local teams. And so a couple of learning points from our projects. From the paper, obviously, early identification of high-risk patients, followed by early standard treatment leads to better care and enormous cost avoidance. Number two, health systems are complex, and doing simple things, even like delivering standard of care, can be really difficult. And finally, we need really innovative new ideas to redesign the health system to get the results that we want. So linked to these learning points, just a couple of reflection questions for you to consider to finish off. How can you shift the focus of diabetic foot ulcer care towards prevention and early detection? Number two, what old practices might need to be eliminated to deliver a new standard of care for diabetic foot ulcers? And finally, how do we empower positive outliers that deliver excellent outcomes to be more efficient and deliver care to more patients? Again, thanks so much for this opportunity to speak, and I look forward to your questions at the end of the session.
Okay, John, thank you very much. And moving on very quickly. We now have Joel Allen, who has worked in management consulting in the healthcare industry for over 30 years across the Americas and Europe. He is an adjunct professor at the Faculty of Information. He has taught in the Masters of Health Informatics program with the Institute of Health Policy Evaluation and Management, Faculty of Medicine, University of Toronto. He has also taught at the Faculty of Information and Media Studies, University of Western Ontario. He's a member of the Innovation 100 Global Knowledge Leaders, which includes several global thought leaders and practitioners in the field who play a role in shaping the new knowledge-based economy. Joel is also a faculty member with the Kaiche Institute for Knowledge Management. Joel is the executive director of the Canadian Podiatric Medical Association. He is also co-chair of the Pan-Canadian Diabetic Foot Committee, an interprofessional initiative between the CPMA, Wounds Canada, Diabetes Canada, and several other organizations. He is also on the steering committee for the New Limb Preservation Alliance. Joel, please take it away.
Thank you. I'm just going to try and pull up my deck here. Okay. So I will be focused, pulling up the closing batter spot, as they say in baseball. I'll talk a little bit about the Limb Preservation Alliance, which we pulled together rather quickly at the beginning of September, actually during August. We launched it at the beginning of September, and it's really an alliance it's a network where we're focused on things like driving advocacy and awareness, and I'll come back to that. There are 4 organizations that are involved. The American Limb Preservation Society, who runs DFCon on a regular basis, CPMA, DFoot International, and Wounds Canada. So we have a global footprint and an ability to kind of move things along. That is something that we're actually looking forward to doing. So we got regional, national, and international organizations lined up to do this, and we are looking for other organizations who will join us and work with us as we move our agenda into 2024. This is a group would be preaching to you, preaching to the choir if I read this slide, but you know the problem with people losing legs because of diabetes. And you've heard the other speakers tonight talk about why it's important that we deal with this issue and some of the approaches that we have for dealing with this. So the American Limb Preservation Society is a nonprofit organization. It's set up to promote interdisciplinary teams, advance science, clinical care, advocacy, awareness, and education in limb preservation. So that's one of the partners at the table. The Canadian Podiatric Medical Association is the national podiatry nonprofit that I run in Canada. Brings podiatrists together. We work in conjunction closely with Wounds Canada on a number of initiatives, including the Pan-Canadian Diabetic Foot Committee. And then there's DFoot International, which a number of you would know, and I don't need to say too much about them. And Dr. Abbas did a nice introduction and underscored the importance of what we're doing. Wounds Canada, who is a nonprofit and charity advocating for best practices in wound prevention and management. The Diabetic Foot Committee that I co-chair with Dr. Evans is a committee that Wounds Canada acts as a secretariat for, but it brings a number of organizations together. Brings foot care nurses, the NSWAP nurses, Diabetes Canada, vascular surgery, a whole bunch of players to the table, where we're looking to advance and move policy and frameworks in that area. In September, for Peripheral Arterial Disease Month, we ran a campaign that was largely social media, and it was relatively successful in terms of reaching out and engaging people in conversation. Public awareness, bringing together a number of different organizations and a number of different things to get the message out to a number of different stakeholders, patients, policymakers, payers, the general public, and healthcare providers amongst the various stakeholders that we're dealing with. We're currently running the Diabetes Awareness Month campaign. And if you follow any of the organizations, you'll see our reach out on social media in particular. And we encourage you to amplify the message by sending the messages off to your networks and the people that you deal with. This is going to be this is not a half-hour presentation, and it doesn't need to be, which will leave time for some questions and things, Dr. Maharaj. But under consideration right now, we are aligning with IWGDF evidence-based practice guidelines. We're looking to identify global policy priorities that will support and drive policy for diabetic foot and limb preservation into the future. That's what's driving us. And this will inform our activities, which are right now fourfold: awareness, advocacy, education, and research, all aimed at getting us from where we are to policy. So a number of the things that I've heard are other speakers talk about tonight: the need to move this along, the need to make system change, the need to encourage and adopt various epistemic approaches like the toe flow and go model. These are all things that we will try and amplify and push out. We're looking to grow the Limb Preservation Alliance and to broaden, to make sure that we have vascular surgery and endocrinology and other folks at the table with us in driving this message out globally and driving policy change ultimately globally. So you can find information on the Alliance through CPMA or Wounds Canada or the American Limb Preservation Society or DFOOT. We're putting information out. As we move forward, we may have our own website and our own web presence. We may have global meetings and a number of different things, but all of that is under consideration. What we're working on doing right now is we're working on making sure that tactically we continue the social media campaigns that we're involved with. We supported International Podiatry Day in October. We had Diabetes and Pressure Injury Day, Diabetes Month and Pressure Injury Day in November. And then we start into the new year, and then we have April, Limb Loss Month. In May, we have both Foot Health Month and Nursing Week. In September, we come back to peripheral artery disease awareness. And there may be other things that we add to our social media and general media strategy, because we're moving from a social media approach to reaching out in various jurisdictions to the media itself, hoping to find a presence in the non-social media, the traditional media venues as well. So having said that, we'd encourage organizations to reach out to us and to join us in these efforts, and to join us in our agenda of trying to drive policy priorities globally for diabetic foot and limb preservation. So thank you, Dale, and I'll turn it back to you and leave you with a bunch of time for questions.
Brilliant, Joel. Thank you very much. So let's go straight on to our question section. So can I invite members of the audience and the panel to shoot some questions at the presenters? While people are thinking of their questions, I'd like to show this slide for two reasons. The alliance between North America and the Caribbean has been there for quite a while. So you could see my good self. I had a lot more hair back then with my professors who taught me in Albany, upstate New York. The second important part about this slide is I really would like to see a continued alliance and sharing of knowledge between the North American regions and the Caribbean. We do need help. And I do believe that we can as well share some ideas, little things that we've tweaked in a low resource area. And I want to invite everyone from North America to come visit and soak in copious amounts of saline. So having said that, do we have any questions from the audience? Dr. Kumar sends his apologies. He had to leave to go to the airport, but he invites questions via email, which I think the IDF can share with all the participants after the meeting.
Hi, my hand's up. No one's paying me any attention.
Okay, Simon, that's you.
Were you trying to ignore me?
Not at all.
Okay, so first of all, really like to thank the speakers. Brian, thank you so much. And John, thank you so much. Well, Kumar is gone. But it's awesome and very kind of heartwarming because as we struggle here in the Caribbean to put things together, we're seeing your perspective, your side from a different perspective. That is, you kind of have it, but you don't. I just wanted to hear from both of you, both John and Brian, if you had to give us any words of wisdom or advice. You know, we are, the Caribbean is seen as a vast, multicultural, multi-political set of islands. We have different policies and politics and bureaucracy. We've got the fist fighting and everything going on with our surgeons and so forth. And I know you've spoken of your own challenges as well. So it's kind of heartwarming to know that we still all have challenges, but it's a different type of challenge. And I just wondered if you had any, if you had to say, well, let's work a little bit together, any words of advice of saying, well, from a political perspective, from a policy perspective, what do you think was that one thing, or is that one thing that would set you into the next zone of, well, I don't know, can we ever achieve perfection? I don't know. Yeah, I know there's a lot of nuances, but just from our perspective, where we don't really have, I mean, Guyana has a diabetes center, but a lot of the Caribbean islands don't. A lot of the Caribbean islands think that they're the amputation capital of the world. And we have not a lot of congruency coming through. So I would love to hear anything you have to say on that.
Sure, I'll start. Yeah, I mean, the landscape for podiatry in the U.S. Is constantly facing its own challenges, and I faced them, early on in my career here in Houston, but really kind of continue to face that on a daily basis. Not only challenges from other podiatrists, but also, other colleagues, orthopedic, general surgery. So I understand, that there's a lot of politics involved, a lot of personalities involved. Some of the ways that I've come to overcome some of these things is just, actions speak louder than words. Working together with these partners and really making it all about the patients. Forget me as a surgeon, the needs that I have. Certainly there's things that I need to be able to have some success in these institutions, but at the same time, I make it all about the patient. And, when it comes down to having conversations with hospital administrations, with the higher ups, chiefs of medical staffs, it's always about, it's never about me. It's always about how can we provide better care for our patients? How can we, those buzzwords, reduce those length of stays? How do we ensure that there's continuity of care with those patients? How do we make sure that those patients are getting seen by the right entities? And by doing that, I think it certainly has helped me as an individual kind of network through some of the challenges and some of the murky waters of the big hospital systems that, employ physicians to manage some of these patients. I go into hospitals now as a private person, a private physician, and, there's a lot of challenges, but at the same time, we still getting constant referrals. On a side note, my colleague and partner, Dr. Miguel Montero Baker, the vascular surgeon, also faced many of those same challenges walking into institutions that already have quote unquote vascular services, but can't provide the care. And what's happened over time, we've been doing this for 12 years. And so what's happened over time is that people realize what our intentions are. Where our intentions are to manage these patients, take care, and really offload the systems of the burden of this patient population, because we know what works and how to take care of them. And then in turn, continue to feed the system. I take my cases back to these hospitals to operate on these patients. If I have complex patients that need other type of, foot or orthopedic work, I refer them to the orthopedic surgeons. Will I get much in return from them? Probably not. But at the same time, if I'm not getting the pushback from them, if I'm not getting the hurdles put in front of me from them, I would consider that a success. Some of the other things that have been done sort of as an outside is we've been working really hard through the American Limb Preservation Society, trying to create more networking type things. And that this is not just a local effort. This is a global effort, building sort of a networking platform where we can have individuals that have, having problems connecting with individuals to help build those teams, but also that are having issues just kind of locally. We've all probably have faced some of these same challenges in one way, shape, or form. And I think, as long as you talk through those experiences and find out ways to navigate through them together, you will be successful. And so you should never feel that you're alone, even though you're sort of isolated, like the foot is on a peninsula in a little island. There is help and support. And I think, learning from these kinds of conversations, working with other organizations that are building platforms to help connect the right components for you, I think will help to make that difference in the long run.
Yeah, thanks.
Sorry, I was muted. Thank you.
Thanks for the question, Simone. I think, when I think back, when I started medical school, it would be in 1996, so it's coming on almost 30 years now. And one of the first lectures I had at the time was a professor who said there is a gray tsunami coming to Canada and the United States. We have an aging population, and we know there's going to be a higher chronic burden of chronic disease like diabetes. And if we continue to do the type of care we do right now with a focus on end stage care rather than on prevention, we're all dead. And so now, almost 30 years later, and I see, the gray tsunami is on us. The diabetes is the new plague, and we are still delivering the same care with the same emphasis on end stage care. And I think the biggest benefit you have over Canada and the United States and the Caribbean is you have a young population. So I would say to you, don't make the same mistakes that we made. Focus on keeping your communities healthy. Focus on prevention and early detection and treatment, and never get to the point where you need to be spending your billions on end stage healthcare. In Canada, we spend 13% of our GDP on healthcare, most of that on the last 2 months of life, and you never want to get to that phase.
To be honest, I think our patients will just die. We wouldn't spend that money. They would just die. But I think when I look across the world, I feel as if we almost have to try to find a way of making diabetes sexy. We need to get the right players in, first of all, because when I'm actually in Antigua right now, helping with the diabetic foot training program. And, the same things come up, exactly quite of the similar things, which is, how do we move from here? Everyone's excited about it, but then it's just making that little change and shift. And I guess we know that change is always difficult, right? Change is not something that anyone takes on very easily. But learning from each other, supporting each other, and I guess impacting your wealth of knowledge, but also your time, which I'm very thankful for tonight. It's not going to go, it's definitely been a really useful time. So, and then what Joel is looking to establish with the Alliance, I hope will have a further impact of raising the awareness within the Caribbean, because I do think that some of it is also lack of knowledge, of knowing what you don't actually know. I think that's kind of where we are here still in the Caribbean. So thank you very much for that.
Okay, great. Any other questions before we conclude? Nobody else. Okay. So Simone, you want to do the vote of thanks and conclusion?
Oh gosh, that's me talking again. All right. So on behalf of DFA International, the North American and Caribbean region, I'd like to thank you, John, you, Brian, thank you very much, and Joel, Dale for hosting, Ali and DFA, all the teamwork of being able, because we are hosting this across this entire week, and poor Ali is up at different times of the morning, like 1 o'clock in the morning, etc., just to be able to facilitate this. So it's the passion of the diabetic foot that keeps us going, and it's also the passion of persons like yourselves who are willing to give us time to share. And I think sharing in a way is kind of caring, where we're able to find ways of getting into those little tiny boxes that we cannot do. And I guess one of the visions I've always had for the North American and Caribbean region is bringing key players together so that we can build a community of resources. So, for example, in the Caribbean, we don't have enough vascular surgeons. We have no podiatric surgeons. So I'm laying a foundation as well here in the Caribbean, and hopefully that we'll be able to then have where, as Dale said, you don't only come and visit, but you make a change. And maybe in your own space, you're not making enough of a change, but you might be able to come and make a change here. and give back, and vice versa, because sometimes, as they say, you don't always get it in your own tongue. So thank you very much, all of you, Mariam and Monique, for your support, and all of those, Will Dale, very much so support, for, you know, helping me navigate the Caribbean part of the NAC. And I look forward to meeting you all in person. We do this on an online program because we figure it's very difficult for people to always travel to be able to be at a seminar of some kind. So at least this is a snippet that gives people some kind of something to uplift them with regards to diabetic foot management and support them. So I want to thank you all for your time, and I look forward to meeting you at some point.
Thank you, Simone, for your continued leadership. We really appreciate it. You're the glue that held us together in the region, and we look forward to continuing to learn from each other and growing as a network and growing and aligning with the global community in DFOT.
Well, I should say thanks for all the for supporting me with all the nudging and the questions and I know I'm a nuisance. I'm probably like that fly that never goes away. But thanks anyway for Mariam and Joel for your support as well. And I hope you have a good evening, guys. It's almost 9 p.m.
Yes. So thank you, everybody. Let's make this an impetus for a regional North American wound care / diabetic symposium.
Yes, that's what we're doing. In person.
Joel, Brian, please, John.
We can't hold it in Trinidad, though. We got to find a country that's safer.
Come to Houston.
Barbados in the spring. Mark my words.
That's a plan. How is Galveston?
Fine, Barbados is going to be good. We're safe in Barbados for sure.
Yeah, no, we'll pick
what time of year you prefer? Get away from the winter.
We'll pick this conversation up as early as Monday, Simone.
Oh, excellent. You know, I'm always ready.
I know you are. We're counting on you.
Thank you.
Thank you, guys.
Thanks so much. Night, night. Bye-bye.
Night, everyone.